All right, so I'm going to go ahead and get started. So welcome everyone. Thank you for joining us for this next installment of the Population Health Seminar for the Next Gen Precision Health Initiative. For those of you who don't know me, I'm Julie Kapp. I'm an associate professor in the School of Medicine and the faculty research lead for the Population Health pillar of Next Gen Precision Health Initiative. So it's my pleasure to introduce to you today Dr. Gillian Bartlett. She joined MU in 2020, so just last year. From the Department of Family Medicine at McGill University in Montreal. Dr. Bartlett specializes in primary care research and knowledge translation. Her current concentration is on knowledge translation and stakeholder engagement around healthcare utilization and outcomes for vulnerable populations, implementation of precision medicine using patient-oriented strategies, and the use of education innovations to advance the discipline of family medicine and primary care. Dr. Bartlett has a strong interest in research capacity building and is currently the president-elect of the North American Primary Care Research Group. She completed a 10-year role as the Research and Graduate Program Director at McGill. She led the development and successful accreditation of 3 training programs that now have over 100 trainees enrolled, and an MSc in Family Medicine, a PhD in Family Medicine and Primary Care, and the Clinician Scholars Program, which is an enhanced skills 3rd-year family medicine residency program on research skills. So her appointment here in family medicine includes an appointment as the School of Medicine's first Associate Dean for Population Health and Outcomes Research, a position that did not previously exist. So it's really exciting to have her join us, and I've asked her to talk with us today about her vision for this position. So thank you, Gillian, so much.
Thank you, Julie. And I'm going to try the sharing of the screen to see how that works out. It's always a challenge. Can everybody, let me just see if I can get the slideshow up. Can everybody see just a single slide?
Yes.
Okay, perfect. Thank you for this opportunity, Julie. So when Julie asked me to give this talk, I thought this would be a great time to talk about how I am seeing the development of population health at the School of Medicine, but also how it links to the precision health initiative and the next gen and everything else, all the exciting things that are going on at MU. So I'm very pleased to be here. Just to let you know, I do not have any conflicts of interest other than publicly funded peer-reviewed grants that I hold. Mainly all in Canada at the moment, and slowly moving those into the US. So I'm going to talk to you today a bit about population health and some of the more current status of population health, where what my vision is for population health and outcomes research at the School of Medicine, and how I see that tying into next gen and different parts of the campus. And I will try and end in time to take questions or comments or anything, so that we can have a dialogue about this, because obviously this is my initial envisioning, and as things develop and mature at the School of Medicine and with MU and Next Gen, this might be adopted. So let's talk about what is population health. I didn't realize that Julie said this is a new position. There are people doing population health research for sure at the MU and School of Medicine, but not a lot. So I thought it'd be good to start at this point. So population health is basically the health outcomes of a group or of individual people, including the distribution of such outcomes within the group. Now that sounds very dry and theoretical, but basically we're looking at whether all of these factors, how they impact these factors, and the ultimate measure, of course, the ultimate research outcome is mortality, our death rates. And there is a link between policy and programs that mediates the determining factors, and the outcomes have a circular relationship with the determinants. So in other words, if your race, ethnicity, your economic status, where you live, your gender, can all impact your determinants, which then impacts your health. So, but this is a very good conceptualization of population health. You will notice down here, genetics is part of it. So I'm going to come back to that. And another important thing to notice here is health-related quality of life. So we're talking about health, not just in the sense of the absence of disease. it is about how you're living and how well you're living. Currently in population health, most population health research occurs at university-affiliated hospital-centered populations. By the way, that's us. The School of Medicine is university affiliated, and they've got a wonderful hospital and lots of family medicine clinics, but they are university affiliated, so they're more closely linked to researchers. And I'll get back to where that might be a problem. Also, population health has focused on traditional risk factors and outcomes, and that's not always reflective of the complex reality we have today. Another limitation, and I'm sure that Julie could tell you a lot more about this, as could others, is that genomics and genetics are not systematically included into population health. It's not that they're never, but it's not a part of the mindset for the most part. And we have a very siloed approach to research. So, you're either researching cardiovascular disease, or you're researching neurology, or you're researching cancer. And we don't tend to look at the fact that there's often people who fall into all of those categories when we're looking at population health. So the result is that researchers are highly trained in very specific topics or areas, and we tend to have very limited team science approach. And training is reflective of this. We train in the area and not across research paradigms. So we have a little bit of the Moses on the Mount approach to implementation. In other words, like, we do fantastic research and we figure, like Moses, if we just present this amazing knowledge, it'll get incorporated, and everybody will think how wonderful we are, and patients will be better off and clinicians will be better off. And anybody who's done any kind of research that even touches on implementation science or read anything about it knows that that's not working. So there's a disconnect to clinical practice and needs and other stakeholders, because if we're talking about health, it's not just clinicians. You have got patients, you've got people who aren't patients yet, and you have got policymakers, payers, all sorts of people in this game. So that approach, which is kind of the current status quo, is not working. So when I think about population health, I think about it this way. This is a study that was done first in 1960s and replicated in 2001 with very little change in the breakdown. So they surveyed 1,000 people on how they use the health system or their health. And 1,000 people in 1 month, less than one. So in 1960s, when it was done, you had one person in 1,000 that was hospitalized in an academic medical center. So that's what we are. So 41 years later, when they replicated this study, did less than one. So the number had gone down. So for me, the population is not just this little tiny white square where I would say 95% of health research funding ends up. For me, the population is this whole square. So it's the 1,000 people, whether they're healthy or not, whether they're seeking medical care or not. So this takes a little bit of rethinking, because funders and researchers are far more comfortable in this little white square. But you can see that's not what I would consider a population. So the other thing that typically happens in population health research is that these things, healthcare and individual behavior, are the main determinants that are examined in relationship to mortality or the occurrence of disease. And for me, it should be all of this, especially the genetics. And it should be all of this, not just looking at mortality, but looking at quality of life, looking at disparity caused by these different factors. So it's not just an individual and the healthcare system, it's their environment, social and physical, and it's their genetics. And I'll give some examples. My own research focuses on a lot more than this, but this is complex research and you need multiple skills. So this is the outcomes. It should be far more than mortality. And so another thing when you think about population health, so I've told you about the actual population. These are the determinants and outcomes. The other thing is implementation. So how do we get it into practice? This is actually one of my favorite translational science graphics. And it lists a lot of the aspects that we should be thinking about. You've got basic health research, preclinical, clinical implementation, public health, and you've got patient involvement. And you see that they're all connected. And on the outside, you've got what I consider implementation science, which is where you develop new approaches, demonstrate their usefulness, and disseminate findings. But where's population health? Where are the different populations in this? They have the patient. Not every patient's reflective of their population. The other thing about this, when you look at this, where are the clinicians? The people who may not be researchers? Where are the payers? Where's industry? They're a really important partner. And you can't come up with solutions to problems if not all the people that are part of the original problem are at the table. So they do have implementation science, but for who and by whom? And this is where I think we've got a lot of work to do, and where I have an idea I'd like to develop and work with all the different players at MU to make it happen. So I want us to rethink population health. This is one of my favorite quotes. As you get to know me, you're going to realize I love quotes. I love them to illustrate examples. Some people like artwork, some people like different things. I like quotes. So this is one that I really like. If I find it really relevant for anything. That is, don't cling to a mistake just because you spent a lot of time making it. And I have certainly made mistakes in my own research career that I've tried to learn from and move on from to make research more relevant and useful and have an impact. Some of you have heard different quotes about this, like, if you keep doing the same thing, expect a different outcome, that's what makes you crazy. This is the original quote for that. If you always do what you've always done, you always get what you've always gotten. So I'm hoping that coming in as Associate Dean of Population Health and Outcomes Research, that we're not going to do what has always been done in population health research, and hopefully we'll have a different result and a more positive one. So my vision for population health is to be the preeminent source of innovative, impactful population health research in the MU School of Medicine, creating an effective learning healthcare system through capacity building, training, stakeholder engagement, and collaboration. And I'm now going to go through what I mean by capacity building, training, stakeholder engagement, and collaboration, because those are sort of the how I envision moving a vision to practice and to measurable, demonstrable differences in population health and population health research. So first is data capture. And here I owe Rick Barron a huge thanks for recruiting Russ Waitman as another Associate Dean to the School of Medicine, because this I can then now count on Russ to do his best to enhance some very solid building blocks for data capture, but ensuring that we're capturing more than just people that use the system and more than just people who are suffering ill health or chronic conditions. We really need cradle to grave, and we need more. If we're trying to target underrepresented minorities or people who are not getting access to care or people who aren't doing well in healthcare, we need this type of data capture. And what I'm really excited about with some of the work that Russ is doing with different people and we're doing in collaboration is getting data capture that's responsive and timely. So not that I'm working on data that's 5 years old. And where this is particularly important is if anybody's doing any type of research that's pre and post COVID-19. Care delivery changed overnight, and people's health changed overnight, and people's healthcare seeking behaviors changed overnight. And we need data that can reflect and capture this if we want to have health research, population health research that's meaningful. So I am looking forward to building up this capacity. I think we're well on our way. Of course, I want not just health data, but I'm really hoping we can get the genomics data on this if we want to insert that precision health piece. The other thing that I mentioned is getting all of this information. Now, to get all of this information, you need different players across campus. So the genetics, that needs to be a key part of, and you know, Julie is the director of precision population health, but we need the genetics piece. We need to be thinking about biobanking. We need to be thinking about GWAS studies and how that's captured. We currently do not have any rarely have genetics, not completely no genetics, but rarely have genetics in our clinical records, which would be an important data resource. On MU campus, we've got some great departments in arts and science, including, we've also got the School of Nursing, we've got the vet school, agriculture, we've got School of Health Professions. They are experts in a lot of this area right here, the disparity factors, and also in policies, the Department of Economics. There's people working on health communication, so policies and programs. And we have a great partnership with MU Health. So we have real opportunities to do a complete capture on exposure and outcomes for meaningful population health research. So this is sort of where I'm envisioning going. And how are we going to achieve that? So now I'll go into those 4 things I talked to you about. And Neil Armstrong said research is creating new knowledge. So this is how I expect to create new knowledge and have what I consider innovative, cutting edge population health research. So how are we going to achieve the vision? So first, capacity building. So I've already mentioned the data resources. I'm going to just very hopefully, I don't know if he's on the call or not, but I'm just going to dump this on Russ Waitman's plate. He's doing some great things, and we've got some great partners at both with MU Health and Cerner and different other partners that will help build this up. The other thing that's going on at the School of Medicine that I am part of, but certainly not driving, but I feel will really play strongly into achieving the vision, is the cluster hires in the different areas. And why I feel this is that I feel the cluster hires where we're doing this on a conceptual level, not on an individual person by person hire, and we're trying to work towards a vision, will enable more of team science. So we'll know who's around and who can work together to really push things ahead in the area of population health. And this will, I'm going to get to how we're going to manage that. The other thing I want to talk about that we are rebuilding is the academic biostatistics unit. And this is sort of a bit of an announcement at the same time. So the biostatistics unit is coming under my mandate, and it will be housed in the Department of Family Medicine, but it's through my associate deanship that it will be run and organized, and it will not be a fee for service unit. And what I mean by that is that at the moment, and it's well done, you log on and you may ask for time, and depending on what you're asking for, there might be a charge or not, and departments contribute, schools department. This will be an infrastructure investment on the part of the School of Medicine. So there will be, I will be under my mandate, there will be a senior biostatistician, associate director, and we'll be hiring to, right now we're on the skeleton crew, we'll be hiring to increase our number of PhD biostatisticians and our data analysts, and we will have administrative support. So there will be a way to log in. With this unit, it's important to understand that, I mean, this is not going to happen overnight, and we're certainly not going to like cut people off on July 1st. It'll take some time to work towards this vision, but essentially, I'm expecting that 40% of a biostatistician's time will be on, when I say indirect some grants, I mean the percent effort in grants. So that's where you put them on for 5 to 10%, and they work with you to develop your grant. 30% will be on service and grant prep. This is where people might need help with pilot data to prepare articles that would increase their chances of getting funding. And also there might be some work with the residents or medical students on their projects, or clinicians who have unfunded projects but expect research productivity to come out of it. There will be time set aside for them to teach, the biostatisticians to teach in the different programs. And there also will be a certain amount of protected time for them to do their own research. This is really important. If we want to develop research capacity, we need cutting edge biostats methods. That means our biostatisticians need to have time to develop this work and to explore these new areas, and so that they're not all complete generalists working at a fairly low level in terms of biostatistics. So we're working to set this up to make it clear and transparent how you would access services. I will put it out there right now that priority will be for federally funded grants, but we will be supporting all research endeavors and initiatives at the School of Medicine, and I will be meeting regularly with the administration and the different players within the School of Medicine to ensure this unit aligns with the strategic priorities for the School of Medicine and for the development enhancement of population health and outcomes research, but it will be for more than just that. So we will keep your eyes on the website. We'll be updating that in July when the official move happens. And if you have any fantastic biostatisticians, let them know there'll be some opportunities for hires coming up soon. The other thing that I see as part of the capacity building is training. If you're paying attention to Julie's introduction for me, obviously training and development of training programs is near and dear to my heart. I have stood up 3 accredited programs in areas that people did not expect, a very successful PhD and master's. I am very, very excited to work with Mark Hennick and Alan Parrish to put forward a School of Medicine Translational Bioscience PhD. This will be an umbrella program. I'm putting this up here so that you see why I think this is important for developing population and research outcomes. The candidates going into these, there's 6 emphasis areas currently under this PhD. So these are the emphasis areas: biochemistry, biophysics, cancer biology, infection immunity, integrative physiology, nutrition and exercise physiology. And the last one is population and precision health. Additional emphasis areas may come in as the School of Medicine grows, but we will be accepting up to 20 PhD candidates per year into this program. And how it works is the first year is supported by the School of Medicine. They are going to be doing lab rotations and seminars to select their thesis supervisor. I think you call it the chair here. And we'll have seminars and journal clubs with the full, they will do it on a cohort basis. So the full cohort will continue to interact throughout the program, no matter what emphasis area they go into, and we'll be training them, of course, covering the human ethics, grant writing, and they'll have a comprehensive exam. This is this is the core training of the PhD. In the fall semester, they take a molecular and cellular biosciences, and they take a data design and analysis. So this course is something that I had developed at McGill. It is a combination of epi and biostats and R programming. So it means that they're learning things in an applied way as they go through, and what's covered in the study design and the biostats would be relevant for basic scientists as well as population health researchers. Once they get into the second term, they can then specialize in their emphasis areas. So this is where I'd be expecting our population health candidates to be taking intermediate epi, intermediate biostats, and then eventually advanced epi and advanced biostats, along with other courses. The rotation research is mandatory. It's 1 credit hour per semester, and it allows them to work with potential supervisors. This is the idea, to get them placed sooner and to make a better match. They also attend research seminars where they'll hear from people across the School of Medicine doing research, so they get an idea of what is available. I will be teaching skills for translational bioscientists, and that is 2 credits that cover 1 credit per semester, but it runs through both semesters. This is the course where it's really targeting all the students and trying to make them more effective scientists. So this is what will be covered in this course: effective writing and communication, protocol development, human ethics training, research and lab management. We expect a lot of times for our trainees to absorb soft skills. In this program, we're going to explicitly teach them so that they will be stronger and better researchers who are more competitive in the job market coming out. For that reason, we'll also cover career development. And here we'll start with the foundations of implementation science. So with frameworks and research paradigms, equity, diversity, and inclusiveness in research, not just in recruitment into the program, and underrepresented minorities in research, and team science. I am hoping, I know there's the Cancer Center is looking to develop some of this. I know that some of this might happen at Next Gen, but I'm hoping we'll have more advanced implementation science courses available to our trainees as we move forward at the School of Medicine. But the basics will be covered for everyone in this course, and they'll understand that they need to not only communicate with their peers, but how to communicate with different people across the system. So it's using all the research paradigms. So we'll be teaching them what a research paradigm is, why the first one, quantitative post-positive, dominates health research, but why you need the second one, constructivism, which is asking the why questions and really figuring out why you have problems in implementation science. And the reason, why am I concerned with this, and why do I think it's important for the training program and for our own researchers, especially in the development of population health research? It's because of implementation. So post-positivism, which is what most of you are familiar with, is where most evidence is generated as quantitative research. Constructivism, which is qualitative research, is critical to implementation. You need to know why something may or may not work. And all of my PhD trainees in the recent years, and certainly ones that will come under my supervision in this PhD program, will have both skill sets. And it makes them very competitive because then they've got a strong implementation science going forward. So what other programs that I expect will help to develop capacity is the Masters of Science in Academic Medicine. This is for residents and practicing clinicians. We are currently developing a strong research stream, and I'm hoping at some point we can have an adaptation for implementation science within this as we move forward. There is a Grow Scholar program that's currently run by David Mayer, and it's mentored grant writing for clinicians. This is not specific to a department. Very helpful, and we'll be looking at how to incorporate that for different clinicians in capacity building. One of the things I'd like to work with across the School of Medicine with the different people is continuing medical education for researchers, clinicians, and stakeholders. And the thing that is very popular right now in continuing medical education is something called microcredits. So you don't commit to an entire master's or PhD. You take very small selection of training that's specific to what you're doing right now. And that is something I'm hoping we can develop, especially as we move into inclusion of genomics into population health, because that will be a new area for many people, or as we move further into team science or further into implementation science, which is definitely a new concept for many people. And then, of course, it's the inclusion and incorporation. So it's coherently incorporating our med school trainings, including the summer research trainings and quality improvement training for residents in all the different departments. And the other thing that we need to think about is stakeholder engagement. I'm sure many of you are familiar with the leaky pipeline. Basically, it's this notion that here's where priorities for research funding are set. Here's where research comes out and gets put into practice. 17 years, really long time, tiny drop. Now, sometimes when you're going from discovery to practice, 5-10 years may be a very reasonable timeline. Not everything in evidence should be put into practice, but maybe more than a drop should be put into practice. And one of the issues why we have the leaky pipeline and why it's still a problem is that when funding comes up, the whole way we apply for funding and it gets reviewed and it gets implemented, there's nothing in that process that assures the relevance and fit of that research to the needs, circumstances, and populations of those practice or policy applications. And you're seeing this, by the way, with COVID and vaccine rollout. It's, what people need and the answers they need to reassure their patients is not what's being necessarily provided, and that's being provided may be distorted. But there's a lot, there's more than this. So when we look at our population in the state of Missouri, we have different needs than when you look at America as a whole or different populations. And when you look at Colombia, we're not the same as the rest of the state. So you can see where it's important that we have this relevance and impact. And one of the ways to do that is to achieve stakeholder engagement. Typical research, you start your project, you end your project, and then there's this long gap, there's that leaky pipeline that's where you may or may not get uptake of the evidence that you've generated. So those what they call the valleys of death between all this types of T1 to T4 research. You can fall off, there's a lot of stuff that doesn't make it through those valleys of death and a lot of reasoning. But one of the things that will help with those valleys of death, it's not completely foolproof, is if you have stakeholders at the table at the beginning. And one of the things I've specialized is this type of research. So I do patient partnered research, or I do stakeholder engagement to develop research programs. I do stakeholder engagement to identify implementation barriers. So they're at the table pointing out what are the challenges potentially going to be and the types of answers that are needed. So it takes longer to start a project because you have to build those relationships. I think at MU we're fortunate because with the extension and with different mechanisms and with the richness of the schools and faculties available on the campus, a lot of these partnerships exist now. So it's a matter of taking advantage of them and leveraging them before you begin the projects, and hopefully you have at the end of the project, you have the knowledge uptake and the implementation, the next steps are clear. Another thing that would be really important for uptake of evidence, this is something I will be working very hard in my mandate, both as a professor in family and community medicine and as associate dean, is to create a loop between researchers and clinical practice by using the quality improvement and critical appraisal that needs to be practiced in practice. And this enables everybody providing healthcare to be a part of this, not just people who are research. But for this to work, you need residents and clinicians who are research literate. They need to be able to consume the literature we're producing. For this to work, you need an active and robust QI cycle. So the clinicians, and a way to communicate to researchers so that the clinicians can let researchers know when and what is not working and where they have evidence gaps. And the literature is not always a great place to do this. You really need the link to clinical practice. And there also needs to be a way to communicate so that researchers are not producing evidence that cannot be used in clinical practice or moved to clinical trials in any way, shape, or form. That doesn't mean all research should fit into this. There's still some theoretical research and knowledge evidence and discovery that needs to occur. But this would be a very important mechanism to get research, such as the type of research I do, into practice more quickly, find out what is and isn't working and tweak it and create a continuous knowledge cycle. So one thing I would like to see happen at MU is creation of a community of practice for collaboration. So this is a figure showing what a community of practice works like, and you have members, and I'd like these members to be across the School of Medicine as well as people outside the School of Medicine. They have a common theme or purpose that you build up trust and share knowledge, and then that creates shared practices. So the PhD is one mechanism, but we need to do this at the researcher clinician level as well. And that creates collective intelligence, becomes implicit knowledge, and you can solve problems. The benefits, now this is tricky to achieve because you need a modality that makes it work. And COVID has highlighted a problem we've all had, which is how do we communicate? So even though we're on a campus where everybody can kind of walk, which is fantastic, that's already a step in the right direction, we still don't have a common communication space. So this is something we will need to work at creating. And the reason we want to create this, and why I especially want to create this for population health and outcomes research, is these are the benefits of a community of practice. So I'm looking at this from the associate. So you can think of this from your level, like what are the benefits here? meaningful work and help with challenges, access to expertise. I'm looking at it from this level, which is long-term value for an organization, which is increased strategic capabilities, keeping up to date, innovation, retention of talents, and new strategies, because that's really where I want us to go. So this is why I think it's so important to create this community of practice and to support and develop the training programs that will make collaborations across different disciplines possible. So I want to finish up soon so we can leave some time for question periods. So what's the future? How do I see the future of this? What do I expect to accomplish with this? I like this quote from Albert Einstein, that if we knew what it was we were doing, it would not be called research, would it? So there's another quote I didn't put on here, is that, if you don't know where you're going, that's kind of where you get to. So I want to say this is where I'd like to get to, and then we can figure out the best path to get there. And that will be my ongoing work for the next 3 to 5 years. So this is how I see MU School of Medicine population health research working. I expect to achieve innovative, impactful population health research, and the building blocks for that are collaboration, so developing a researcher community of practice, capacity building through data resources, cluster hires, and the biostats unit, training through the Masters of Science in Academic Medicine, PhD, grow scholars, hiring of postdocs, and continuing medical education for our researchers and faculty, and stakeholder engagement. So engaging with industry, providers, patients, community, and the extension office. And what I think that will result in more implementation, and that will result in an effective learning healthcare system, which is, I think, where we'll see true gains going forward. So that's where I'd like to get to. I also want to introduce one more complexity for this. I've used the term implementation science a lot. I don't see my role as a population health researcher and an implementation scientist as being two silos. They're extremely complementary, and I think they're necessary, because this is how I actually see population health. So this is an example from my colleague Laurette Dubé from the from the Faculty of Management at McGill University. We've been working together for a long time. I can always count on Laurette to push my thinking and broaden my horizons, whether I want them broadened or not. And she is working on this notion of convergent science. And this is where I see population health and implementation science combining. So this is an example from neurology. And the issue that we were tackling that was made incredibly apparent with COVID-19 was social isolation. So if we had a community of practice, we should be able to develop this version of population health. So this version of population health that's tackling social isolation has information from animal models, neuroimaging, neurochemical profiling. So this is the animal models here. It has information from our ecosystem, like about behavior, environmental exposure, spatial data. So you can think about geography and all the different complexities of determinants here. It then, you can do targeted experiments, so lab work, clinical trials. And here you have the population health research. So we look at neuroimaging, sociodemographic, genetics. We need the GWAS studies. We need that information. So that results in here multi-scale brain pathways, multi-scale society pathways to determine what is happening with socialization, how do we mitigate it, and how do we improve the health of the population. So this level of complexity is how I expect us to create a learning health system and go and link research to excellent care. So I realize I have touched on a lot of topics. I know there's a lot of very practical questions in terms of how do people access research, become interested in research, go forward with research. I have tried to keep this higher level. The next little while, we'll be delving into the weeds in terms of how do we accomplish this and how do we work synergistically with other strategic priorities that are occurring at the School of Medicine, MU Healthcare, and on campus. So I'll leave you with this. I love this, I love this cartoon where you have the simple but wrong answers and a huge lineup of people and the complex but right. And you can see this is a steep, windy path that only a couple of people are on, but I'm hoping that others at the School of Medicine and in the Precision Health Initiative will embrace the complexity. So I'm going to stop there and take questions. And I will actually stop sharing my screen so that it's easier to see people.
Okay, thank you so much, Dr. Bartlett. And the first comment was from Dr. Barrett saying you're welcome for hiring Dr. Waitman. Then I'll get into the questions. And so we have from Dr. Kim now, will the biostatisticians be available to faculty from other schools and colleges? And how do you envision the biostatisticians working with other faculty across the campus and the system?
So I have actually recently had a conversation with the School of Nursing about this. I think the health professions is another one that uses these resources. With the biostats unit, the priority to begin with will definitely be the School of Medicine, but we've got ongoing commitments that we have to manage and determine the best model. What I'm hoping to do is that as and we are working with the Department of Biostatistics, I'm in communication with them. What I'm hoping to do is as we become more of an academic biostats unit, biostatisticians hired elsewhere will be able to be affiliated with our unit. So that's going to be their home where they can talk to other biostatisticians about methods and approaches. And obviously, as we develop cross campus initiatives, the biostatisticians are going to support those because I think those are going to be the ones that are really competitive. And I'm hoping to have a fairly transparent mechanism for utilization of the biostatisticians' resources. And then it's going to be ongoing monitoring and negotiation as to how that gets supported. But one of the things is as we increase our number of grants, they're going to need more biostatisticians, assistants, and we want to make sure we can meet those demands. So I realize that's a politician's answer, Kim, but basically we're going to see how this develops and how we can support everybody to meet their biostatistical needs, and whether that's through the unit or affiliations with biostatistics across the campus will remain to be seen.
Thank you. Who do you envision or from what fields to be ideal candidates for the PhD program? Are there pipeline undergrad system programs that position competitive candidates for this PhD? And she also mentioned, as you know, she's thrilled to see this program and your leadership in this space as it has enormous impact potential for next gen.
So as Kim knows, flattery gets you everywhere, but Kim, I'm definitely going to be tapping you on the shoulder for some of the programs. So we expect shortly to be putting this in for approval. We got 3 different layers of the system to go through before final approval. Recruitment will become active for fall 2022. And we are expecting 1 administrative support person who will be a recruitment specialist. So we will be looking for those pipelines. Having supervised a large number of incredibly talented PhD students from all sorts of backgrounds, what I find is if you ensure your core training is strong enough, you are just looking for incredibly motivated, bright people to go into this program, and they can get the skills they need in the program. So I'm less worried about them coming in with a certain skill set, especially since we'll be taking them from undergrad, and more concerned that we get our equity and diversity mandate met, and that we are seen as an innovative, interesting, competitive program. And then I think we're going to have our choice of the best minds.
Gillian, thanks. I'm just jumping in for a second, Mary, for this conversation. Thanks for that answer. I think as I look across the faculty and folks who've joined this call, Gillian, I think that point that you just made was why I prompted the question, that this is really, I want folks in veterinary medicine and veterinary science and other fields to think that this is open to their candidates as well, because that motivation for doing population health can come from any corner.
Absolutely. I actually, in my PhD, I shared an office with a vet who was doing an epidemiology degree, and I just saw her on Facebook And I'm like, wow, you are prescient. You're so in demand right now because this notion of viruses jumping from animals to people, and that was her area of study. So she was ahead of the game. But when I developed the programs at McGill, we did exactly that. We took people from all backgrounds and we mixed them in with clinicians. And wow, that was a lot of fun, convincing senior people, both at the government level and the university level, that that was a good idea. But I'm like, we cannot do team science and implementation if people are not mixing at the training level. So I'm really hoping that this will be of interest to, it may not be everybody's predominant PhD trainee, but I'm really hoping we will get PhD trainees from the other schools and faculties, because the more the trainees mix, they're our bridge. I had a graphic I used in one talk about this, where I said, you know, when I first tried to bridge clinical and research, and you can think about School of Medicine and the rest of campus, and it was a picture of the Spider-Man when he's trying to keep the split ferry together, and he's the one holding all the reins, and it obviously is not working. And what works is when, sorry, yes, I'm a complete geek, when Iron Man comes in and all his little robots push from the outside. And I saw those little robots as our trainees, and they're going to push us together. So that's my vision. And now you know both that I'm a little crazy and a lot of a nerd. I'll put that in the next slide.
Dr. Phillips shares, this is all very exciting, and I like that you consider the current context of transitioning from pandemic response to vaccination promotion. What has been surprising throughout the past year is the lack of understanding across many disciplines of public health and our public health systems in this state. There's now a lot of momentum towards building on the synergy between public health and clinical and acute care professions. Are you considering public health systems content in the PhD program curriculum?
Okay, so yeah, public health. I've actually written blogs on the synergy between public health and primary care. One of the things that is interesting about public health, and I did a MOOC on disease screening in public health, and one of the things I did in the background is covered the historical development of public health from where it was really about infectious disease and protecting the rest of the population from infectious disease from an versus an individual. And our healthcare system is very much on the care of an individual. And public health is still about the good of the population. And I think we need to explicitly teach and address that dichotomy, because what we are getting now is the confusion. We have lost sight that there are certain things for public health that we do for the good of the population as a whole. And what's ironic is that public health is back now into the days of plague and tuberculosis, when they had no treatment for it, where they were quite fine with like isolating and to the fact that people would die in that situation to protect the rest of the population. But it's been a long time since we've had that mindset, because they've moved more to chronic disease prevention and health promotion. But now we're back to infectious disease and what that means. And I think that we need to re-examine that. And I'd really like, if anybody in history is doing anything on the history of medicine or the history of the development of population health, to come and talk to our trainees and our faculty, because we have lost sight of how things develop and why we do the things we do. And we're so entrenched in the weeds that we don't realize that this is not a new problem.
Thank you. Dr. Kapp shares that she's glad you touched on clinicians and residents as stakeholders, as it is an area that she hears about now and did when she chaired the SOM Research Council. Our clinicians want to be involved and support research, but don't know how to get started or how to help. Can you expand on how you might strengthen connections between clinicians and full-time researchers? How do clinicians find out how they can help? What is the platform for the community of practice?
Okay, so I can answer the first ones. I will be meeting with the residency directors to figure out what their curriculum is, both for scholarship and quality improvement critical appraisal, to see how we can support that. We will, with the biostats unit, be holding drop-in sessions so that when people have an idea, they're not contacting a biostatistician one-on-one, but we can do it in a group. It's almost like group therapy for research. We can do it in a group setting where we can talk about, okay, where are you at? What do you need to do? Make those links. Julie herself is an excellent link she knows everybody across campus, and she's a great resource for that. So it'll be a matter, we will have events like that, and we'll be working with the School of Medicine to determine how do we manage that. How do we distinguish between research literacy and researcher, and so that we don't have the expectation that somebody with an interest in research can do what somebody like myself, who has 12 years training in research, can do. But we want to encourage it. We want to encourage the curiosity and the thinking that comes in the research modality. So it's a matter of creating a spectrum for people to be involved. And I expect to do that slowly over time. So I don't have a clear, immediate answer for that, but I'm working towards that. In terms of the platform for community of practice, this is one area where COVID has really helped us out, because I have been doing blended learning, which is a mixture between what's recorded online and what you do face-to-face, which is not virtual, which is what we're doing right here, for 5 years or more, and train people who now lead ed tech divisions. And it was an uphill battle to get anybody to consider anything online. Like, teachers hated it, students liked it, but then the blended learning wasn't always done well. So what COVID has done for us is not only made people realize that they don't want to be teaching on Zoom forever, so what are the alternatives there, but also given us access to more sophisticated, user-friendly, affordable platforms. So I don't have an immediate answer for you on that, Julie, but because I'm president of an international conference where we've got to hold it for the second year in a row virtually, I'm hoping that we'll be able to come up with some really, a really nice platform that's easy to use and easy to communicate on, so that we can interact, and also creating some in-person events as we move forward and hopefully get boosters for the variants, and we can move forward to more safe in-person, because innovation occurs with that personal interaction, and that is important to foster relationships and innovation. So I'm hoping we'll have some ideas on how to make that work both virtually and in person. And I'm going to tell you what's not going to work, and that is email. I came to that conclusion a long time ago, and my mind has not changed with the advent of COVID. So.
Thank you. And I think this kind of speaks to some of Dr. Kimenow's next question about infrastructure for a wider stakeholder engagement. But I wonder about if it touched on working with industry and clinicians in industry.
So industry is one, so I chaired a peer review committee, or what you call a study section committee, for 8 years that was industry university partnerships. And what we were looking for and what got funded were true partnerships, not tokenism, not industry having a clinician that they pay as a consultant, and not us saying, oh, we let them know about the project that got funded. So this partnership where there's benefits on both sides of the equation and where we work, I think is going to be critical for moving forward both next gen and population health and the data infrastructure we need. So we do need to create a mechanism where we account for the very different accountability in industry and needs of industry, but to be able to speak with, that they could be a part of our community of practice. And it can't be just that it's, people who have an idea that could spin off and be profitable. It's really got to be working together to address common solutions and coming up with barriers that will work on both sides, solutions that will work on both sides of the table. So yeah, this platform that Julie's referring to, much the way Zoom allows a lot more people to attend meetings than would otherwise be able to for these type of seminars, that platform is going to be critical. And universities tend to use learning management systems like Canvas, and at McGill it was direct to learning. That's not communication friendly. So I'm hoping coming out of COVID, we can figure out something that is somewhere between Zoom and Facebook and Canvas. There'll be something else that works for us and we'll be able to use.
Right. Dr. Quinn mentioned that the Show Me Echo is a suggested modality for education, training, and the development of communities of practice. And there's been a request
Show Me
for
Echo is an interesting example. It still tends to be a little like they're developing capacity for clinical practice in rural settings, done some fantastic work with how they get people engaged and how they're training them because a lot of it is online. I would like to take that very, very positive example but enhance it so that there's more of a flow of communication and a level of engagement. But I am working with Dr. Quinn with her team, and I'm really excited to what's going to be happening next. She's got a lot of the players I need already at her table to move ahead the training mandate. So it'll be exciting to build on. That's what I mean about already having great building blocks here at MU. Kathleen's work it means I'm not starting from scratch, and I'm so happy, and I've really enjoyed working with the people that she's already got engaged for her projects.
Great. I've quite a few more questions. Can you expand upon the intersection of your role with that of Dr. Spertus and healthcare delivery, given your focus on implementation science within the clinical context?
Sure. As much I've met with John a few times. I'm going to Kansas City to see him in May because as I said to him, I'm seeing the outline of what he does. I probably committed to help him do what he does, but I don't quite have all the details nailed down. So he's working in a very specific area. He's got some great community engagement. He's got some great clinical knowledge. And I think what we're going to do is take his clinical implementation experience and expertise and marry it with my more research, academic, implementation science, stakeholder engagement expertise, and hopefully we'll come out with that slide I put at the end. So I do see him much the same way I see Dr. Quinn as a really important part of what's already being done that I can build on and leverage and tweak and come out with something really fantastic. So yeah, I'm really excited about his role as well, and we are working together.
Yes, and he was on the call earlier. I see he's stepped off. Dean Zweig mentions the NIH acts as if most important questions have direct answers and that science only progresses through a series of these answers. You were suggesting that complex answers are not just a string of simple ones. How do we help people begin to think that way? How do we get funders to pay attention?
So I'll deal with the easier question first, is how do we get people to think that way? People need to be exposed to it. This is where the community practice is really important. They need to hear other people's perspective. This is why I do patient partnered research. I do work with on implementation for pediatric brain cancer, and I don't want the perspective of a parent whose child has died or died of brain cancer. So that's where I rely on my patient partners, and I tell them they have a PhD in lived expertise. So we need the people at the table talking to each other. If that happened, we would never again have the development of an intervention that's expected to occur in family medicine that would take 1 hour of a clinician's time, because they would understand that clinical visits are typically 6 minutes. And a 1 hour on one problem is not going to work. And a lot of people would understand that all the evidence they're generating in clinical trials, that if you go into a family medicine clinic, you can look around and pretty much see the exclusion criteria sitting there waiting to be treated. So we need those kind of perspectives and people to be talking with each other, because then you get a broadening of the horizons, and you get the understanding of the complexities of care. One thing that's really fascinating to me, because I do implementation science across the spectrum, is people's lack of understanding of how patients travel through a system, whether they have insurance or not. And so that's really interesting. And these are the things we need to address to increase the complexity. One of the things that I think funders and researchers have been a bit slow to pick up on is all the easy questions have been answered. We are left with the complex, wicked problems. And our old way, so one of the other quotes I love is that it's by Maslow, and it's basically that if every tool in your toolbox is a hammer, you're going to see every problem as a nail. So if we increase what people have in their toolbox, they will then start seeing problems differently. Now, the way we get funders to change their mind, okay, funders, peer review committees are our peers. So as we train and change our own thinking, we need to make sure we're being involved in those decisions, and we're doing the peer review so that we can express this complexity and start moving them away from, because don't forget the funding model, when you do it by disease, simple answer type approach, is easier to administer. Complexity is a lot harder to administer, but we can get there. But we need to start basically, I'm such a geek. Michael Jackson, if you want change, you need to start with yourself. I should probably stay away from pop culture. But
Starting the man in the mirror. That's right.
Yeah, the man in the mirror, we need to start here. And what we need to do is demonstrate success with this approach, because that's what speaks to funders.
Thank you. Dr. Keen, how do you envision that the population health and implementation science priorities will be determined? How do all of the efforts come together as a comprehensive and coordinated whole at NextGen?
Sorry, I was just looking at the chat, which I should not have been doing.
That's
Can you
okay.
repeat that, Mary?
Yes, how do you envision that the population health and implementation science priorities will be determined? How do all of the efforts come together as a comprehensive and coordinated whole at NextGen?
That's an excellent question. If you have any ideas, no. So one of the first things that we really need to get a handle on is who's doing what and how. And so one of the things I expect to take 3 to 6 months with the biostats unit and just track where the effort is, where it's going into, who's putting in grants, but not only who's putting in grants, who's getting grants, because there is an expected success rate. And then what do we need to do to change that? So where's the training most urgently needed? Where is the support most urgently needed? I think that it's really helpful that the School of Medicine is doing a joint strategic vision with MU Healthcare, because that helps put in the broad strokes and allows me to keep it's sort of a check system. So, okay, is what I'm thinking of what I'm doing and what we're doing matching those strategic visioning? And I know NextGen is going through the same thing. We've got the cluster hires coming up. So I like what's happening now, that a lot more people are communicating and trying to get in lockstep and rowing their boats in the same direction for strategic visioning. And I'll be keeping an eye on that to help ensure that we're moving along the same pathway. And this is an iterative process. It's like a programmatic or developmental program evaluation. You look at what's working, you continue to do that, look what's not working, you change it. Is that working? No, change it. Is it working? And eventually you get something that works. And so this will be iterative. I am very, very open to new ideas and perspectives. I've always found that benefits any work. So I'm hoping there'll be a way we can have those exchanges to move this forward.
Thank you. And you had mentioned history of medicine, and Dr. Catt mentioned that Dr. McElroy and others across campus are doing work on the history of infectious disease. So the next question from Dr. Oler is, as an NTT statistician, I'm excited to see the development of the biostatistician PhD in faculty, as it's much needed. As an applied economist, I'm excited to see how and CHRI can contribute to this implementation science agenda. Looking forward to learning more.
Thank you. And I had a meeting with Cooper Drury, and we're looking at how arts and science can work together for some of the things we're doing. And I will continue those types of meetings, and really happy to hear from people who want to be involved and contribute and that we can support.
Great. And there's
Thank
another
you for this
comment
opportunity.
about recommendations, and so I'll get that to you. Does anyone else want to come off of mute and ask a question? Or and I really appreciate your presentation today, Dr. Bartlett.
Yeah, you'll have to give me a copy of the chat, because I think there's a lot of information there that
A lot of great questions and suggestions. Yes. I'd like to remind everyone that May 4th, we have an important topic, team science, at our NextGen Precision Health Discovery Series, and would love to see everyone there. Reach out to me if you haven't heard about it. And Dr. Brian. Yes.
Yeah, just want to throw out there that Dr. David Pittman is doing a great job building the biorepository capabilities, and he has headed up that effort through the School of Medicine, but it's broader than that, because from the College of Veterinary Medicine, I'm involved and some others. So if you have biorepository interests or input, David Pittman is your person for everybody on the call.
Absolutely. One of my PhD students is actually, she produces some of the SOPs for biobanking across the world. And I'm very interested in that. I think it's a critical part And I'm very interested in the notion of us being able to do this across species. So yeah, that's thank you for that. And this is great because I'm really glad to hear some of the resources. I knew they were out there. I just didn't know exactly what they were. So thank you.
Thank you. And so this presentation was part of the science seminar, the Next Gen Science Seminar under Dr. Kapp's role as faculty research lead for population health. We're utilizing the Canvas site. All of you, I believe, have been invited to be part of that. And there's lots of discussion space and places to communicate and move things forward here at MU. Please let me know if you need more information about that.
Thank you very much for
Thank
having
you.
me. Julie, thank you for this opportunity you created for me. And I look forward to ongoing discussions.
Gillian, it was fantastic and we're happy to have you here and so excited at building all the partnerships. Thank you.